We'll move back to the NDP caucus and Ms. Chender.
Thank you, and thank you to the panel for being here. We, as I'm sure all of you do, wear several hats on this side. We are legislators, we hold legislators to account, and we also work in our constituencies. And I have the privilege of working in a constituency that is home to now, I think, the third largest hospital in the province in the form of the Dartmouth General, with a catchment area of a little over 116,000 people. And in my short tenure in this role, I see people on a daily basis who ask about physicians and family doctors and hospitalists, and it's far and away the #1 issue in my riding. So I'll apologize in advance if some of my questions might be a bit more specific and a bit more patient-focused, but I'm sure we can extrapolate from those. And so I want to start with picking up this question of succession planning. We know, and I've spoken to some of you about this, that we're losing over 40% of our family doctors in Dartmouth inside of less than 5 years, which is a chilling statistic. Dr. Harrigan mentioned in her opening comments that the Central Zone had no formal strategy until 2017, I believe, no recruiter. And so, you know, on the one hand, it's sort of shocking and chilling, as I say, and on the other hand, it's completely common sense. It's a simple demographics. We have older physicians who want to retire, and in fact, I know anecdotally that many wanted to retire 5 or 6 or 10 years ago and are not retiring because they know what the impact will be. And with Dr. Gregus's recent retirement, with whom some of you will be familiar, we have now 1,000 plus more people, many of whom are reflected on the most recent stats of the list and who have been into my office. So I guess I'm wondering if you could speak a little bit more about what, if any, succession planning has happened in the last 5 or 10 years. Like, how did we get to this place where we have 40% of doctors retiring in a single community and no, as far as I can tell, hopefully you can correct me, real hope in sight for rapid replacement of those folks? You know, why didn't we recognize this earlier? I guess that's my first question. And I'm not sure who it should be directed to, whether it's the health authority or the department.
Ms. Knox.
Or Dr. Gibson.
So thank you for that. And I think what you're talking about is we've come to a point in time with the health system of Nova Scotia that we have years and years of challenges behind us, and we're coming to the realization that we need to do things differently. And so I can't answer why 10 years ago we weren't planning succession, but we had a very different system then, and many family practitioners were very independent of the rest of the system, and it just was what it was. And so where we are now is at a pivotal time in our history where we are trying to understand what are the needs of Nova Scotians, what are the areas where we need to focus, how do we work with our physician colleagues in planning for their future together. They are in the driver's seat on that, but to be talking about what does that look like and how do we need to work with you to plan for your succession. So I would like, if you would indulge me, to ask Dr. Gibson to talk about, this is his work around Nova Scotia.
It's his community too, so I'm always happy to hear from Dr. Gibson.
Dr. Gibson?
So yes, I think that actually, it's a really interesting question, and why was it the way it was 5 or 10 years ago? This actually highlights the importance of having a single health authority and the work that we're doing. So 5 years ago, I was the chief of family practice for Capital Health. And at the time, physicians in the community, in their offices, did not have to be credentialed. So we didn't know actually how many family doctors were out there in the community because they were independent business people practicing in offices that they were responsible for creating and operating. And they came and went as they chose to. And when it came down to matters of recruitment, it was entirely their responsibility as independent business people to do that. And as a health authority, we had no responsibility over them and no ability to help them or to ask them to do anything. So on the occasions when I went to people and said, would you like some help with recruiting for your practice? The almost universal answer from the doctors 5 years ago would have been, no, that's our business, stay out of it. Now, we're in a much better position because they are credentialed. So to Mr. Houston's earlier question, yes, I do know the age of the doctors in all of the communities in Nova Scotia because they put their birth date on their credentialing form. And so we do know their birth dates, their ages, and we do know which communities face larger numbers of people that are approaching retirement, but you cannot assume with physicians that they're going to retire at the age of 50 because, or 65 or any other age. They just retire when they want to, and a lot of them work till they're 70 or 75 by choice. So now we're in a situation where, and we've gone through this process of approving vacancies, so now when they're going to depart, they tell us that they're going to depart. And the good news is that now they're telling me they're going to depart in 2019. So we're getting ahead of it in the sense that I know somebody's going to leave or planning to leave or
Well,
thinking
that's a
about
whole
leaving.
practice that's going to close in 2019, is my understanding.
So then we're into the question of, okay, we know there's a practice, and the question is, and we are helping with the recruitment. And then you get into the question of, so what are the practices in the community and what happens when you take a candidate out to a given practice to have a look at that practice, and what's the messaging they get when they're in that practice. And sometimes that's quite interesting, either the messaging from the community or the messaging from the colleagues in the practice or the messaging from the management of the practice. So it speaks to this earlier conversation about it takes a community to recruit a doctor, and sometimes as a health authority we're saying we'd welcome you with open arms in this community, and it's quite interesting the message that the doctors get when they actually go and look at a practice, what their colleagues in the practice would tell them,
So
which explains some of the challenges.
Yeah, no, I appreciate that, and I'm only moving along because I have a limited period of time, and there are a few other questions I want to get to. I'm going to leave that question for a moment, but looking forward, I'll just flag that, you know, we are, as my colleague brought up, in many cases, these practices are, you know, the old model. And so I recognize that there are going to be big issues with recruiting there, and I'm hopeful that there are some innovative strategies at play, and maybe we'll be able to come back to that. But in the meantime, you know, I think this is connected to the physician resource plan that was brought up recently in terms of identifying needs. And my question is whether that plan and or the triage for the 811 line, Ms. Knox, you made a kind of interesting comment that we'd hear something soon about this. Does it take into account the needs of the folks on that line or the needs of the folks in a community? So I'm asking two questions, but they're a mirror question. So for Dartmouth South, for instance, for many of us, we have a lot of seniors in our community. We recently had a situation where we found out about a new doctor that was accepting patients, and we keep a list, and we called every single person on the list in our office and said, this doctor is taking patients. He didn't accept many of the people who had been in our office, because the people who come to us are the people who have really hit the end of the road and are looking for any resource they have, and their health needs were too complex. So I'm asking about seniors with complex health needs. I'm talking about people living in extreme poverty who may have multiple other challenges. I'm talking about pregnant women and women who are in need of prenatal care. Are we triaging those folks either at a community level or at a kind of that 42,000 need a physician level? I'd love any answers to those questions.
Ms. Knox?
Okay, all right.
Ms. Perrett?
So there were several questions
Yep.
there, and I'll just start with your question specifically about the physician resource plan and
Yep.
whether it takes that information into account, and the answer is yes. It looks at population
Okay.
health. We've got very good information on population health status throughout the province, and that's absolutely taken into account.
Thank you.
Ms. Knox?
So your question about the people on the list, they're of great concern to us. And the list as we have it is just that they need a physician, and we don't know who they are. So we are working with the department to see what are our options in terms of what we can do there. But we are both very concerned about that and need to, that's the transition of getting to where we have access in local communities for Nova Scotians. We have to deal with this population now, and we need to look at different strategies, so innovative, creative, different strategies that will get to those needs.
Thank you. I also want to ask about what those 100,000 people or 42,000 people, or in my case, several thousand people and growing, are meant to do when they require the services of a family doctor and they don't have one. And I'm not talking about having a kid with strep throat, which I have a lot, but because, you know, there are ways to triage those things. But I'm talking about, you know, when the Dartmouth General Pain Clinic closed, I have an elderly constituent who was told that she needed to go. She had been a patient at the pain clinic. When someone finally returned her phone call after she saw on the news that it had closed, she was told she needed to go back to her family doctor to get a referral to the QE2 pain clinic. Now, luckily she had one, but if she didn't, what would she have done? But because I have limited time, I'll also just mention the other things that have come through all of our offices, which is people who are applying for income assistance or disability support, people who are applying for CPP disability. The list goes on of, you know, tasks that I know are challenging for family doctors at the best of times to be able to complete. Nonetheless, those are still things that we require of family doctors. Are there provisions being made for patients so that they can find those services in another way until we fix this situation?
We'll go with Dr. Gibson.
Those are very important issues, and you raised a couple of different issues in there. One is the issue of medical care. You've quite properly said that when people have acute issues, there are options for them to get their acute care. It's important that people have chronic issues and get their chronic issues looked after, and that's the conversations that we're having with the Department of Health around, you know, what are the options for those people. And interestingly, the forms issue is when you've actually raised a question of uninsured medical services, because filling out forms for Canada Pension or something else is actually an uninsured medical service. So I don't know that it's actually the responsibility of the Health Authority or the Department of Health to ensure that people have access to doctors for uninsured medical services. That's an entirely separate. It is tangentially related, because if you are disabled because of a condition and then have to get the form filled out for Canada Pension, it's connected, and it's not something that can be done by a doctor that doesn't know you, but it's not what the Department of Health is paying doctors to do. It's a related but uninsured service.
Thank you. That's very interesting. So maybe there's some other department we'll ask that question of in the future. I guess I have only a few seconds left, but if Dr. Gibson, maybe you could speak to how we're going to fill those 50-odd vacancies in Dartmouth. I'd love to hear your thoughts.
Dr. Gibson.
So we have the recruiter on the ground, and she is actively, you know, interviewing or meeting with candidates and touring them around and showing them the vacant practices where we've got good information about the practices and what those opportunities look like. You know, as alluded to, we need to find a way to work more closely with the community to present Dartmouth as an attractive place to practice. I mean, Dartmouth in particular is kind of the demographic thing. It just happens because of a variety of circumstances. A large number of doctors are hitting retirement age at the same time. And so we are faced with that. It is generally an attractive place to practice. Been doing it for 35 years myself. So, so we should be able to fill the vacancies. We are having success filling vacancies in a variety of locations in Central Zone.
Order, I'm sorry, time has expired.